let's move on from dual checkpoint blockade to the role of locally ablative therapy in patients who receive immunotherapy. And we will have some data, it's actually being presented today at World Lung, looking at local ablative therapy in patients who have advanced non-small cell lung cancer, up to 4 sites, and giving the radiation first or surgery, it could be either one, followed by pembrolizumab every 3 weeks. And the outcomes look fairly competitive. Again, this is not a randomized trial, but the PFS is 25 months. All PD-L1 expressors were allowed, but it gets to this point of the idea of tumor heterogeneity and trying to knock out everything up front with a local measure and then following it with immunotherapy. Is there room for this in our treatment paradigm, given all the complexity with chemo, IO, dual checkpoint blockade? Is this something where we may see some traction? There's a lot of rationale to use radiation prior to immunotherapy, that's discussed by you, Solange, in the Pacific trial. Is this something that may gain traction over time?
Maybe you want to start. I think we like to individualize patients' treatment if we can, right? And these patients with very small number of lesions and restricted also size of lesions are not very often encountered, right? So these exceptional patients with low tumor burden, right, and good probably performance status, the patient for whom you'd like to do a little bit more than just giving, you know, palliative IV treatment, they exist, and we're happy to have this data, but formally doesn't create high level of evidence. So it's about trying to find an individual treatment, but you should still keep in mind that there are standards of care for this patient.
I completely agree with Solange in the sense these patients who have oligometastatic disease are patients who have somewhat better prognosis compared to the others. In a single arm study, when you give them some intervention and show that they do better, we have still not isolated the treatment effect. The good news is these kind of supportive data have already led to a randomized phase 3 trial in the National Clinical Trials Network in the United States. There is a trial that compares patients getting systemic therapy, and after they get 4 cycles of therapy, be it chemo alone or chemo plus immune checkpoint inhibition, they are randomized to radiation to oligometastatic disease and then continuing on with the systemic therapy versus just continuing on to systemic maintenance therapy. And I think that trial will elegantly answer this question and help us change the standard of care.
I think that's right. You know, this is a very attractive strategy for about 20% of our patients that have oligometastatic disease, depending on how you define it. And that's the other elephant in the room, the heterogeneity that we have of the definitions. But I think, you know, these data sets that you're talking about are attractive because they inform us about the safety of that combination. There have been some concerns about different modalities of radiation or surgery and the combination with the immunotherapy, but you know, we're not seeing any major detriments. And as we've seen with Pacific, you know, combining it with traditional radical thoracic radiotherapy hasn't potentially been a problem in consolidation. So, you know, I think we really look forward to having randomized data sets to inform us of the treatment effect.
Yeah, lots common theme in this discussion, a lot of unanswered questions moving forward to hopefully get these answers quickly so we can make the best treatment decisions for our patients. So just briefly want to talk about local ablative therapy in EGFR mutant lung cancer. I think the paradigm has been for many of us that we've started with these patients who are EGFR mutated. We give them a TKI, whether it be a first generation and now a third generation TKI. And if there is progression can be heterogeneous. And one side of that is that you can just have these local spots that grow, and the paradigm has been just radiate that spot and continue the TKI. And we've seen some improvement in outcome, not randomized, but some nice work retrospectively and prospectively suggesting that radiating at the time of oligometastatic progression can lead to longer time on drug and delay chemotherapy. We have a set of abstracts that will be presented at World Lung looking at that same strategy, but using local ablative therapy for synchronous METs up front in EGFR mutant lung cancer as either upfront or consolidation and continuing the TKI. This is a similar story with the pembrolizumab data, a small number of patients. Again, are we going to start using these other types of means, radiation or surgery up front for these local or these local spots and then treating with TKI? Or still the paradigm, give the TKI first because osimertinib has such profound activity in this patient population and save your radiation for when the disease progression occurs. Any thoughts on that?
I would say this is something I think we do already in clinical practice. So that means if you have a patient with multiple disease, and if you see small metastasis, tumor evolution, you try to maintain the EGFR TKI and to have some local treatment. So I'm quite persuaded that we have to treat patients with a backbone, so it will be an EGFR TKI, and just the fact to have stereotaxic irradiation, to perform local surgery, and to try to avoid any local recurrency or resistance, this is something we do in clinical practice for some patients. So it's nice to see some clinical trial to try to see the magnitude of benefit we might improve for this population. But clearly, the fact to make an addition of different treatment in this population, despite if they are considered to be metastatic, we should still be quite aggressive for this population. I'm quite persuaded that we might bring a benefit in quite a significant proportion of patients EGFR mutated with this.